Welcome. My name is Dr. Michael Stifelman, and I'm the chair of urology and the director of robotic surgery for Hackensack Meridian Health. I am so excited to be part of the first ever virtual robotic forum. This is truly an innovative concept, and though obviously a lot has changed over the last 2 weeks, we are not in sunny Miami listening to this talk. But nonetheless, it is an honor to be with you today, and I'm looking forward to sharing a unique perspective that's going to be a little different than some of the other talks. But throughout, you will see that the adoption of robotics to urology really has many similarities to what you're seeing in general surgery. From the adoption of robotic to hernia, chole, and colorectal, there are many similarities. The idea that we can learn the future from looking at the past rings so strong today. It is my goal to share with you what we learned in urology along the way so that you, as general surgeons, robotic directors, nurses, administrators, do not need to reinvent the wheel, and that you may learn from our success and hopefully steer clear from some of our mistakes. I was first introduced to robotics in 2004 with the standard system, published the first paper on robotic partial nephrectomy, and in 2009, more than a decade ago, was appointed the director of robotics at NYU. This concept of building a robotics service line was so crucial to developing a world-class program, and from that experience, we learned a tremendous amount of knowledge. More recently, in 2016, I was recruited to Hackensack as both a chair and a surgeon. Quickly, I became the director of our program, and most recently, I became the system chair of our robotic service line. Throughout this time, I took a lot what I learned from NYU, but we also continued to innovate both our program and our administrative process. And today, we have a strong focus on improving expanded access, as well as developing a successful ambulatory robotics program. There is an extremely important concept in the hospital administrator's vernacular. It's called the quadruple aim. And the idea behind the quadruple aim is that for a hospital to be successful, it must focus on improving healthcare outcomes, lowering costs, improving the patient experience, and improving physician satisfaction. As surgeons and program directors and nurse coordinators, it's crucial that one understand this concept of the quadruple aim, how it defines the goals and strategy of your hospital's leadership, and most importantly, how robotics aligns with the quadruple aim. So how exactly does robotics align with the quadruple aim? Let's start with enhanced patient experience. There's less pain for the patient. There's less conversions. We're turning inpatient surgeries to outpatient. How about with improved outcomes? Over and over, we see decreased length of stay, complications, surgeon site infections. In terms of lowering cost, when you look at the entire episode of care and the ability of robotics to reduce clinical variation, we are seeing a lowering cost of that episode of care. But most importantly, it enhances our provider, our surgeon experience. Ergonomics of robotics, the ability to sew and manipulate tissue more efficiently with more dexterity, the ability to immerse yourself in the operative field in 3D, the surgeon autonomy one gets by having a stable camera and a retractor while working with their left and right hands. And most importantly, the increased technology that we're bringing into the operative field. We now have near-infrared imaging. We've got 3D reconstruction. We have constant data that we can pull into the operative field via TilePro. All of this is providing an enhanced surgeon experience. In the end, though, it always boils down to one thing: putting the patient first. We have performed over 25,000 robotic procedures, but it's just the tip of the iceberg. And each day, our team is constantly innovating, constantly challenging ourselves. so that we may continue to evolve and continue to provide better and better care for our patients, giving them the best outcomes. In the beginning, it was not easy. The struggle was real. However, through this journey, we have learned a tremendous amount about building a successful program. And it's these lessons and these similarities between urology and general surgery today that I'd like to share with you. We have all seen this adoption curve. There's the innovator phase, the early adopter phase, and the early majority phase going out to the late adopters. I picked robotic partial nephrectomy as our adoption curve because I believe it's very similar to general surgery. When we began this journey, there was an open solution to partial nephrectomy. There was those doing laparoscopic surgery to partial nephrectomy, and there was a small number of us doing robotics. And then over time, over a 15-year period, as you can see, the open and laparoscopic approach reduced dramatically, while the robotic approach now approaches 73% of all partial nephrectomies performed. Again, today, I believe there are many similarities between this adoption curve and general surgery with chole, hernia, and colorectal. During the innovator phase, there really was not a lot of attention paid to robotics. There was a big push to perform minimally invasive kidney surgery, and there were many centers doing laparoscopic partial with reasonably good results. However, the skill set was not easily transferable, it was not reproducible, and it was truly limited to the most straightforward cases. And still, open surgery was recommended for the more complex tumors. In addition, many patients who likely should have had a partial nephrectomy were being offered a radical nephrectomy laparoscopically because it was, quote unquote, less invasive. It is here where I and my colleagues stepped in to look at how we could apply robotics to partial nephrectomy with the goal of not only improving outcomes, but creating a reproducible technique that will allow us to manage all tumors, not just those simple ones, but even the most complex ones. It was here in the early adopter phase that we got the most pushback. I will never forget in 2006 presenting at the AUA at a podium presentation of our robotic partial nephrectomy results, and the line behind the microphone for questions kept getting longer and longer with all the same comments. Robotics has similar outcomes to laparoscopy. You just need to learn how to perform laparoscopic surgery better. You just need to learn how to sew better because robotics is just a sewing tool. This is just a fad. This costs too much money. On and on they came with their reasons why we should not be using or adopting robotics. But in the end, it was just that they missed the vision. Good outcomes are absolutely important, but is not the only point. And yes, there were certain laparoscopic surgeons who were getting equally or close to equal outcomes as we were robotically. However, their approach was not reproducible, it was not teachable, and it was not transferable. And at the end of the day, it does not matter how good your surgery is and how good your outcomes are. If you cannot teach it, you cannot reproduce it, it's just a bad operation. And this is where robotics really changed the game. It allowed us to teach our residents, our fellows, and even our fellow surgeons a reproducible, transferable operation that allowed us to manage all types of tumors within the kidney. It was here in the early majority phase where the fun really happened. It's here where the surgeons banded together to share their data, to present it, to publish on it. It's here where the naysayers became the believers. It's here where we work together as partners to develop pathways and protocols and courses so we could not only teach our residents and fellows, but teach our fellow surgeons. And it is here where we have the inflection point. So that in 2020, 74% of all partial nephrectomies performed in the United States are done robotically, compared to just 15 years earlier, where it's less than 3%. As you all listen to our story in urology, I'm sure you're beginning to understand now the similarities to general surgery. Just last week on Twitter, I saw the feed of how robotic cholecystectomy should never be performed. And the comments of the naysayers were the same as they were 15 years ago with partial nephrectomy. They're undifferentiated outcomes. You just need to learn to be a better laparoscopic surgeon. This surgery takes too long. It costs too much. The same comments over and over. So here are some lessons I learned from my playbook to share with you to build a strong robotics general surgery program. It's going to be an uphill battle at times, but persevere. It is absolutely worth it. Make sure that you understand the clinical value of robotics, because with that understanding, you can articulate why it's so important for you and, more importantly, your patient. Don't try to use robotics as a selective approach. I made that mistake early on, and I learned from that. If you're going to do it, go all in, because it will allow you not only to do the easy cases and give you the experience on that early on, but it will allow you to tackle the more complex cases with all the experience you have gained. And probably most importantly, collect your data. If you can, do it in an IRB protocol so that you can share your outcomes as well as combine your data with other colleagues and institutions. I'm going to challenge you that good, prospective, IRB-approved data that you share with your colleagues and other institutions that you publish is one of the best ways that you can drive the adoption curve. The paper I listed here was done in 2009, just 4 years after the first paper on robotic partial nephrectomy. It included multiple institutions, and it showed that in every outcome category, robotic partial nephrectomy was better than laparoscopy. This data was undeniable, and it was this paper, along with many others, which showed similar results that helped drive the adoption curve to where it is today. It's what's going to take your naysayer and turn them into a believer. What my colleagues and I learned very early on is the need for standardized techniques, instructional videos, and courses that help train our fellow surgeons. In fact, over the last 10 years, me and many other of my colleagues throughout the country have putting on 4 to 5 courses a year, helping to train our surgeons in robotics. So now when I look back from this opportunity, I realize it has allowed us not to only treat the 250 so patients that each of us would treat per year, but in fact, by training over 1,500 surgeons, that has translated to us affecting the lives of more than 375,000 patients. In addition, we have the satisfaction that we played a major role in changing the field of urology so that the majority of our surgical procedures, once done open, are now done robotically, even our most complex. And I will add, we are not done. In fact, this is just the beginning for urology. As we incorporate single port, advanced 3D imaging, advanced near-infrared fluorescence imaging tools into the operative theater, we're going to see further success and further improvements in our techniques, and again, in the end, better care for our patients. So as you can see, in the last 15 years, I've witnessed and been part of the change robotics has had in urology. It has not only been an exciting journey for me, but it's really been transformative to the field of urology. And now today, as a director of robotics in a healthcare network, I too see how robotics is changing the way general surgeons are performing their procedures, with their focus on improving outcomes for all their cases, no matter how simple or complex. I see this happening in our HUMC program. I see this within our healthcare system. In addition, across the nation, I have seen this phenomenon. I speak with healthcare administrators from all over and partner with them in our Enrich program with a consistent goal to help them expand their access for their general surgeons. And why? Because they see the value of robotics and how it aligns with their goals of the quadruple aim. I like to end with know your resources. When we started this journey, none of this on the slide was available. But today, all of this is available to each and every one of you. Obviously, in the last 20 years, we've seen tremendous amount of innovation and integration. However, I would argue more importantly and more exciting has been the ecosystem that Intuitive has built to help us drive training, education, support, and analytics. And I encourage you to reach out and partner with Intuitive. Allow them to help you throughout your general surgery journey in terms of the training as well as the education of your fellows, residents, and surgeons. And they can also help you with providing support and analytics as you build your program and you align strategically with their leadership as you focus on aligning robotics with the quadruple aim. Finally, I just want to say thank you and congratulations in taking the time out to join us for this really innovative robotics forum. I hope we provided you with some lessons and some action items you can bring back to your program and your institution. I look forward to spending the meeting with you and sharing more ideas on how to liaison with the C-suite. And at this point, we are open to questions.
Well, thank you very much, Michael. This was really great, and it's nice to see how other specialties have applied robotics. For us, it's especially general surgeons, and it's also important to remember you guys were there first, so we're trying to really relearn things from you. I have an important question, and you showed a lot of data showing benefits of robotics. In general surgery, we're noticing some of the studies that we have can't quite pinpoint the precise patient benefits. Yet those who would understand it's better for the surgeons, it's better for the program. What do you think about outcome measures that are important when you try to convince that the benefits exist?
So I think sometimes we need to look outside of the operating room. I think that's a problem. I think when you start focusing on the continuity of care, or their care just as in the OR, that's a mistake. And I think when we start bringing in longer, timelines like 30-day readmission rate, complication rates, surgical site infections, return to work was something we looked at very early on for a lot of our patients. How quickly were they able to return to work? Those sort of things we are able to bring in and realize that, maybe in the OR it was $500 more or whatever that number may be, but long term, it was actually significantly better. And really, patient satisfaction is the other piece of this. And so when we looked at those, we were able to tease it out a little bit better. I think the other thing about robotics, though, is it really allows for standardization amongst all of your partners. And it's very easy to start looking at costs and what instruments we're using. And I think we've focused a lot of energy the last couple of years, especially here at Hackensack University Medical Center with Steve Pereira and George Mazpule, of really minimizing the cost of these procedures. So they're actually many times less than even the laparoscopic, just in the OR. So those are some of the take-home points I would add.
One quick question. Do you think it'll prolong careers? And is that a good thing or a bad thing?
I think it's a great thing. Absolutely. We don't talk about this a lot. I mentioned the slide a little bit. I mean, the ergonomics of robotics is phenomenal. I mean, at age 38, 39, I was developing sciatica, I was having back pain. I switched to robotics at 42, and I've not taken an NSAID since.
This is audio.
And I do think having, people who can prolong their career and have that experience is only going to be beneficial for our patients.
Conrad, did you have a question?
Yeah, so I remember, I think it was probably 2016, you hosted your big annual robotics symposium, and I went there and realized firsthand how giant of a place NYU was. And we did the robotics symposium, and this was still relatively early on in robotic adoption. But I remember during that time, I believe you had you purchased 7 XIs, and there were 7 XIs on the loading dock, which was unbelievable at that time. What was it like going from the giant that is NYU to Hackensack? So that's my first question. My second question is, the incorporation of robotics in general surgery was super contentious, and probably not as contentious as the transition from open to lap, but very similar. It seems like urologists and gynecologists are quicker to the game than general surgeons. I was wondering if you had any insight to that.
Sure. So, number one, Hackensack is a giant. They're actually as large as NYU. So coming from NYU, which is academic center, to Hackensack was an easy transition, because I would argue equally good. In some ways, Hackensack maybe even better. However, robotically, we were not a giant. Now, if you remember, Hackensack led the way since 2002 on robotics. We were the first place to do robotics general surgery. Garth Valentine, Steve Pereira, and many others led that way. When I got here, though, we sort of, I wouldn't say lost our way, but we sort of maybe lost focus a little bit, and we didn't have the administration and the leadership really dialed in to why robotics was so important in the early 2000s and why it's even more important now. So the only thing I did that changed around, so now we have 5 robots. We've got 3 XIs, we have an ambulatory X, and we have an SP. The only thing I did was I just worked on our communication with leadership and made sure that they understood how robotics was able to really marry and align with their quadruple aim, with what they were trying to achieve. And once we got them to believe back in robotics and the benefits and how it aligns with quadruple aim, everything else was much easier. And today, literally less than 3 years, about 3 years since I took on that role, we transformed our program, and we are doing almost as many cases as NYU is right now. And I would argue we're equally good, if not better, in many ways. So I think the key in that transition, and the key with any program that you're trying to build, is making sure that you are aligned with the leadership team. And if you don't have that open communication and you don't have that vernaculum that they're using, it's going to be a bigger struggle. And in terms of getting people on board, again, for us, it's the data. Collecting that data prospectively, sharing that data. We're doing that here very transparently with all our general surgeons. We have dashboards by procedure, by surgeon. We share that data. And once you start sharing data with people, they see their benefit. They see the areas they can improve on. And it's just a natural wave of excitement. And it's a great opportunity for people to continue to, challenge themselves and get better.
That's great. All right, let's get our Boston crew involved and see if they have anything to ask.
Hey, Dr. Stifelman, Gene Dickens here. Thank you very much for an excellent presentation. I think sometimes the devil's in the details. I think that's a lot of valuable information to help programs really take it to the next level. So very much appreciate your contribution there. And for putting some real academics around Conrad's add to the value equation of surgeons' satisfaction. My question is, what's it like for somebody who's been through this learning curve? And I know you kind of addressed this to some, but is it odd to sit back and see all of us general surgeons fight this fight that you've kind of already experienced?
No, it's actually exciting. And I love partnering with our general surgeons. And, you know, we have an amazing team here. And our team really, we work together. And it's really fun because what I can help with and what urologists can help with is we can sort of help. Everything good over there? I'm just checking. I see a lot of movement. Okay. What we can help, though, in terms of the general surgeons is to guide them on what works and try to show them, hey, this is not going to work, you know, or this message needs to be tweaked a little bit. And I think it's incredibly exciting. You know, when we developed 24/7 access, that wasn't because urology needed 24/7 access. We're doing prostates and kidneys. It's because our general surgeons needed 24/7. And so they came to us, and you know, George Mezpouli said, "I don't understand why at 11 o'clock at night I have to do a different operation than I do at 11 o'clock in the morning." I was like, "You're right, you know, and let's work together to tailor the message out to the administration so that we can, you know, make sure we get what we need." And to watch them grow and to have that 24/7 access, it's incredibly satisfying for us. And most importantly, it's amazing for the patients. It's really just the right thing to do.
Yeah, I can just tell you personally as a general surgeon, invaluable the contributions the urologists have made on the RSC for flank hernia specifically, adrenalectomies, et cetera. So thank you. Yusuf has a question?
I think I need a.
Connor, you're next to moderate, to introduce Elise.
Dr. Stifelman, great talk.
You're going to be introducing Lisa, though.
Go for it, Yusuf.
Dr. Stifelman, great talk. A big fan of your work, and thank you very much for this presentation. I have a quick question. You work in academia and about funding and research. There's a lot of talk about what could be done in research, and maybe you can share with us your experience in the last decade or 2 decades about, you know, how you're able to pull this off in academia. You talked about research and outcomes. I mean, how can we take this to a high level? I mean, you talk about maybe you have a data bank. Who does this?
Everyone thinks that this is difficult, okay? And that's why no one does it. It's this mountain. Like, I don't know, how do I do it? This is not that hard to do. You basically need an IRB. That's it. You get yourself an IRB that allows you to collect your data. That's number one. It takes and every hospital will have someone to help you write that. Number two is you set up a REDCap database. Not hard to do. You go online, you can Google it, you can hire someone for $500 to do it. And then all of a sudden, you are now collecting all your data prospectively. That's step number one. Step number two is you find 3 or 4 colleagues in other hospitals who want to do the same thing. So you use the same IRB, you use the same REDCap data.
Use the same IRB. There you go. Just need an IRB and you're good to go. Yusuf, you got one of those?
Yeah, we do got one of those, but you know, it's.
Okay.
Thank you.
All right, I think.
But last statement though is that within a year, you will be back. You will have so much data that's been collected appropriately under an IRB that you're going to be amazed with the amount of publications you can do. So don't think of this as a difficult thing to do. We've done it. I would say get out there and just make it happen.
Love it.
Thank you.
Thanks.